I'm a pediatric dentist and a biochemist. Folks know me from helping to introduce silver diamine fluoride and driving minimally invasive care approaches across the US and thankfully across the world as well. Um, I am also the director of clinical innovation at an organization called CareQuest Innovation Partners. So I first heard of your gentle Hand-Burs years ago and even had some and wasn't yet using them.
Mhm.
It's a little embarrassing, but I wasn't yet using them until we reopened after the COVID pandemic shut us down. We were very concerned about aerosolizing procedures, and so we were trying to avoid them. I am very adept at silver diamine fluoride and other non-invasive approaches. And as a practicing dentist, I know absolutely there are indications where we need to be invasive. We need to take out a little tooth structure. In particular, a non-cleansable cavitated caries lesion, a class 2 cavity, an actual hole in the tooth where it's a plaque trap. And of course, as many of us experienced when we got back from the shutdowns, there were more than ever because access had been completely removed for everyone, not only the folks to whom it's usually difficult. So of course, I finally got smart, pun intended, and pulled out my gentle Hand-Burs. So first of all, I shared a video with Jerry of my 3-year-old taking them apart and putting them back together, switching the burrs in the device, no problem. Very easy. But it was a profound experience for me. It was a real awakening for me, going back to questioning what we know, questioning what we were taught, questioning what we think we know, of why do we use high-speed burrs, or drills, why do we use slow-speed drills? I never found a great love for slow-speed drills because there was still pain experience, there was still a lot of bumpiness, and the children really react to it. I understand the high speed because it goes fast, right? So we can get our job done quickly, and that's, you know, part of business and efficiency for patients. There's a logic there. But as a pediatric dentist, I treat really young children, really phobic people, and people with special healthcare needs, people who have a no built trust with dentistry. And it was alarming how easy it was to complete my cavity preparation, as is supported by modern evidence, to get a clean margin circumferentially around the lesion, and do just a bulk removal of infected material. The patients didn't need to be numb. The patients did not need to be numb. The patients did not need to be numb. It was amazing. And you know, we got these completed restorations that now we've seen, you know, 2.5 years later, they turn out just as well as anything else. So it's been a profound experience that, to me, after that moment of realization, you know, I went and got a video and like videoed what I was doing, and, you know, showed my friends and said, and I think once you try it, you don't ever put it down. It's just a key instrument in the pediatric dental routine. I don't see why it wouldn't be for any aspect of oral health care. For me, practically, in a busy pediatric dental office, I still do sometimes use a traditional approach where I take a minimally invasive reduction. But if there's any difficulty at all using local anesthetic, you know, if there's any phobia or fear, let's say the vast majority of people under 12 years old, under 6 years old, I just, you know, throw the needle away. I try not to hit anybody with it, you know, throw the drill away. I put out my gentle Hand-Burs, and it's been, I use the Hand-Burs more than I use a drill.